Good morning, ladies and gentlemen. Welcome to week 2, lecture 2 of this course on physical medicine and rehabilitation in sports. In lecture 2, we will be discussing the functional anatomy of the lower extremity. And I am Colonel Dr. Anup Krishnan, and I will be taking you through. Bear in mind that we will be talking mainly about the functional anatomy rather than the structural anatomy intricacies. So, I will be covering this topic as per the following outline: introduction, overview of joints, structure, function and biomechanics, kinetic chain, injury prevention strategies, role of footwear, and as usual, we will conclude with a take-home message. The lower extremity plays a crucial role in weight bearing, locomotion, and athletic performance. It comprises of the hip, the knee, ankle, and the foot joints, and they function together to provide mobility and stability. It is very important to understand the joint-wise anatomy because this helps in optimizing performance, preventing injuries, and guiding rehabilitation. So, the overview of the lower extremity joints. The hip joint, as we have already seen, is a ball and socket joint and it enables multi-directional movement. The knee joint is a hinge joint with a limited capacity to rotate. The ankle joint is primarily dorsiflexion and plantar flexion movement. So, this is dorsiflexion and this will be plantar flexion. The foot and the toe joints are critical for balance, propulsion and for force absorption. The hip joint. It's a ball and socket type of joint mainly formed by the head of the femur and the acetabulum. So, it is also called the femoroacetabular joint. The articulating surfaces are the acetabulum of the pelvis and the head of the femur. The ligaments which protect the hip joint are iliofemoral, which prevents hyperextension, the pubofemoral, which limits excessive abduction, and the ischiofemoral, which reinforces the posterior hip. The ligaments surrounding the hip joint are amongst the strongest ligaments of the body. The movements are flexion, extension, abduction, adduction, internal and external rotation, and circumduction. The muscles surrounding the hip joint are the muscles which cause flexion are the iliopsoas, the rectus femoris, and the sartorius. The muscles which cause extension are the gluteus maximus, the hamstrings, which comprises of the biceps femoris, the semitendinosus, and the semimembranosus. Abduction is done by the gluteus medius and the gluteus minimus. These muscles also prevent hip drop in single leg stance. Adduction is done by the adductor longus, adductor brevis, and the adductor magnus. The gracilis and the pectinis also assist in adduction and lateral movements. The biomechanics of the hip joint. The load distribution passing through the hip joint varies depending on whether you are walking, running or jumping. The hip abductors, they play a key role in stabilizing the pelvis. The common injuries which are seen are labral tears, femoroacetabular impingement or FAI, hip dislocations and trochanteric bursitis. Let's come to the knee joint. The knee joint is a hinge joint which allows a limited amount of rotational movement. The articulating surfaces are the femur, the tibia, and the patella. The ligaments of the knee joint are the anterior cruciate ligament, which prevents anterior tibial translation, the posterior cruciate ligaments, which prevents posterior tibial translation, the medial collateral ligament and the lateral collateral ligament, which provide medial and lateral stability to the knee joint. The menisci, the medial and lateral menisci, which act as shock absorbers and improve the joint congruency. Movements at the knee joint are flexion, extension, and a limited amount of internal and external rotation. The musculature around the knee joint. The flexors are the hamstrings, the biceps femoris, semimembranosus, and semitendinosus, and assisted by the gastrocnemius. The extensors are the quadriceps, comprising of the rectus femoris, vastus lateralis, vastus medialis, and vastus intermedialis. There is some amount of rotation which is possible at the knee because of the popliteus, which unlocks the knee, and the sartorius, which causes medial rotation. When we talk about the knee biomechanics, we have to discuss about something called QH ratio or quadriceps hamstring ratio. This is key to knee stability. The quadriceps hamstring ratio has to be 60-40. If not, if it is deranged, the knee will not be stable. The patella acts as a lever to improve the efficiency of the quadriceps muscle and the quadriceps tendon. In fact, the patella is a sesamoid bone which is found within the quadriceps tendon. Common injuries of the knee are ACL rupture, often in cutting and pivoting sports such as football, meniscal tear, and patellar tendinopathy. The ankle joint. It is a hinge joint, mainly comprises of the tibia, the fibula, and the talus. So it's also called a talocrural joint. The ligaments around the ankle joint are the medial deltoid ligament, which provides stability against eversion, and the lateral ATFL, CFL, and PTFL, which prevents excessive inversion. Movements around the ankle joint are dorsiflexion, plantar flexion, inversion, and eversion. So you have dorsiflexion, you have plantar flexion, you have inversion, and you have eversion. The muscles around the ankle joint are: the main dorsiflexors are the tibialis anterior, the extensor hallucis longus, and the extensor digitorum longus. The main plantar flexors are the gastrocnemius, the soleus, the tibialis posterior. The inverters are the tibialis posterior and the flexor hallucis longus. The everters are the peroneus longus and peroneus brevis. The ankle joint plays a crucial role in gait and shock absorption. The stability is affected by muscle strength, proprioception, and ligament integrity. The common injuries are lateral ankle sprains, Achilles tendon ruptures, and high ankle sprains. The foot and toe joints. Slightly important. There is something called subtalar joint, wherein the inversion and eversion movements take place. So this is the subtalar joints. The midfoot joints, such as the tarsometatarsal and the intertarsal joints, enhance foot flexibility. So the metatarsophalangeal joint allow toe flexion, extension, abduction, and adduction. these joints. So as we can see, there are different types and a variety of joint in the foot and the toe, and each of the joint are important for a particular movement. The intrinsic muscles of the foot are the lumbricals, the interossei, and the plantar fascia supports the foot arches. The extrinsic muscles are the tibialis posterior, the peroneals, and the gastrocnemius, and they influence the height of the arch. The arch stability is provided by the medial longitudinal, the lateral longitudinal, and the transverse arches, which provide stability and shock absorption. Foot biomechanics is again important. There is something called pronation and supination of the foot. So, if you look at the foot, pronation is a combination of movements involving eversion, abduction, and dorsiflexion. All right. So, when the foot pronates, there is eversion, there is abduction, and there is dorsiflexion. When the foot supinates, there is inversion, there is adduction, and there is plantar flexion. So, these are the pronation and the supination movements of the foot. And they are very important because these help to distribute the ground reaction forces while walking and while running. The common injuries seen in the foot are plantar fasciitis, stress fractures, and hallux valgus. The extremity or the lower extremity is essential in walking, running, jumping, cutting, and pivoting. And as you may have appreciated by now, joint coordination is crucial for efficiency and for injury prevention. The kinetic chain relationship. We have already seen all joints and tendons and ligaments of the body are connected to each other by something called kinetic chain. And improper foot biomechanics can affect knee and hip function. If your glutes are weak, it will contribute to knee valgus and instability during walking and running. If your hip flexors are overactive, they can limit hip extension and can cause lower back pain. If your gluteals are weak, they may contribute to excessive knee valgus and cause osteoarthritis. Injury prevention strategies. Most important is strength training and proprioception exercises to improve joint stability and to improve balance and neuromuscular control. There is a very important role of footwear in preventing injuries to the lower limb, and proper shoe selection will reduce injury risk by a large extent. And if there are any biomechanical errors which need to be corrected, you can use custom orthotics for the foot and ankle. Future trends. Wearable technology is coming in a big way for biomechanics assessment, and nowadays markerless assessments are being done in biomechanics. There is a lot of progress being done in regenerative medicine, especially in osteoarthritis of the knee and ankle and hip. Artificial intelligence driven rehab programs are coming in a big way because these help the practitioner to allow minute day-to-day adjustments in the rehab program depending upon how the athlete is performing. The latest trends in orthotics are 3D printed orthotics, which allow you to accurately print the orthotic based upon the athlete's anatomical function. There is a new trend which is coming in called genetic profiling, and it is being used for injury risk prevention. What does a targeted prevention program look like for an lower limb? Exercises including warm-up, stretching and strengthening exercises. Definitely balance and proprioception training will be included. Structured multimodal training programs which will target the muscle strength and neuromuscular control will be included in this prevention program. Nutritional strategies such as increasing protein intake, improving calcium, vitamin D, B12, magnesium and zinc intake and fluids. Technique modification may be advised depending upon what your biomechanical analysis has picked up. Shoes and equipment modification may be prescribed and load management will have to be done in a proper manner so as to prevent further injuries from occurring. So, the lower extremity is essential for weight bearing, mobility and stability. The hip flexors, extensors, abductors, adductors. The quadriceps hamstring ratio is crucial for knee stability. The ankle and the foot muscles support movement and also contribute to stability by looking at the arches. Joint coordination prevents injuries such as ACL tears, ankle sprains and plantar fasciitis. Strength training, proprioceptive training and phased rehabilitation optimize function and recovery. These are the references I have used for preparing this lecture, ladies and gentlemen. I strongly urge you to go through them in the interest of better understanding. I seem to have finished, ladies and gentlemen. Thank you very much for your patience. Thank you and Jai Hind.